So those are the gestational ones. What about chronic hypertension? What does it mean? What it means is that this blood pressure was there even before. Now, how do you know that this blood pressure was there even before? What is your threshold? It's 20 weeks. So if one has blood pressure being high before 20 weeks, then it means that blood pressure is not to do with pregnancy. That's the conclusion we made. Or it could be one who is a non-hypertensive. They've been taking diuretic, they've been taking ifedipine, they've been taking losartan or whatever, and then they decide to get pregnant. They will remain chronic hypertensive. And then, of course, the last one is the pre-eclampsia superimposed on chronic hypertension. So in pre-eclampsia superimposed on chronic hypertension, it refers to a non-hypertensive patient. So a non-hypertensive patient who has been taking nifedipine, for instance, 20 milligrams twice daily, and has been faring very well with very good readings of 120/80 on average. But then all of a sudden, after they cross 20 weeks, you find that they have symptoms, signs, proteinuria, and the BP becomes uncontrollable despite taking the same dose. Then it means that pre-eclampsia has come in the background or in the face of one who already had the chronic hypertension. It's clear, Dr. Dale? Yes. So whenever you make a diagnosis of a hypertensive disorder in pregnancy, you can't just say high blood pressure in pregnancy. That is very superficial. In fact, that is academic indiscipline, because you need to specify. Your diagnosis will end with the pre-eclampsia, PIH, pre-eclampsia superimposed on chronic hypertension, or indeed chronic hypertension. It can only be those 4 categories. Choose one. And it's up to you to either call them mild or severe. Clear? So I've set the stage by explaining the classification of hypertensive disorders in pregnancy. Now let's go to pre-eclampsia itself. So pre-eclampsia is defined as a mild systemic gestational disorder. Mild systemic, it affects several systems. Gestational because it comes in pregnancy, like I have mentioned. Okay, characterized by hypertension, and whenever we talk about hypertension, you're talking about BP greater or equal to 140/90 millimeters mercury, comma, significant proteinuria. What do we mean by significant proteinuria? We are talking about protein in urine of greater than 300 milligrams in 24-hour urine collection. I don't know how you can collect urine in 24 hours. But you can see some people have tried to correlate that 24-hour urine collection into what is seen in the dipstick when you are doing urinalysis. But the standard is 24-hour urine collection. It should be more than 300 milligrams. Then comma again, occurring after 20 weeks, except in 2 conditions, multiple gestation and gestational trophoblastic disease. For instance, in this case, we can think of mother pregnancy, where it can occur before 20 weeks. Okay? So if you claim that your patient has got pre-eclampsia and they are 18 weeks, if we were to buy into your diagnosis, you have to convince us that you've ruled out multiple gestation and mother pregnancy, for instance. Because those are the only causes of early onset pre-eclampsia. Are we together?
Yes.
We have moved from definition. We now go to risk factors. Which people are at risk of developing pre-eclampsia? The first risk factor we have is previous history of hypertension. So this should give us a wake-up call, because if a woman has pre-eclampsia, chances that pre-eclampsia will keep following her is very high. So previous history of pre-eclampsia. Just like preterm labor. If you are preterm labor, chances that it will follow you next time is very high. No wonder people are doing so much research where they are trying to see how you can prevent, because you already have the risk. Why can't you prevent it the second time? Remember, we are coming from shoulder dystocia. We said once you have a history, chances of having another one is high. So that is one of the risk factors. Number 2 is, so it's not just pre-eclampsia, but any other hypertensive disorder. It could have been PIH, could have been chronic hypertension, but provided it was hypertension in the previous, chances are very high. Number 2 is that extremes of parity. What do I mean by extremes of parity? One who is a prime gravida or one who is in their final pregnancy. So prime gravidity, grandma with parity. These two extremes of parity is a risk for pre-eclampsia. The third one is medical conditions. So we have 3 medical conditions which are notorious for bringing pre-eclampsia close. Which are those? The first one is the diabetes mellitus. The second one is sickle cell disease. And the third one is autoimmune diseases. And under autoimmune diseases, there are many autoimmune diseases that I know. But we can narrow down on one autoimmune disease, and that is antiphospholipid syndrome. Again, we talked about it under miscarriages, where there is the autoantibodies forming against negatively charged phospholipids or the phospholipid binding proteins. Very nasty condition, because somebody can end up with pre-eclampsia continuously throughout every pregnancy and end up with bad obstetric history, because you either terminate or discontinue that pregnancy, or indeed they will just have spontaneous issues such as an IUFD or indeed preterm processes. So that is the medical conditions. The other medical condition, if I was to add the other one, would be a renal disease. So somebody with a renal disease of different types might be prone to developing pre-eclampsia. Then the other risk factors to pre-eclampsia is multiple pregnancy. I think I've already talked about multiple pregnancy. The placental surface is huge. So as we shall learn later, the problem is with trophoblastic invasion, mostly. And therefore it will be over a wider surface. And that can be quite detrimental. And then finally, we need to think of change of male partner. So don't just wake up and say, I've changed my husband. Okay? Because we are going to see, we'll talk about immunological theories that look at issues to do with maternal adaptation to a foreign antigen. Because mind you, sperm is actually a foreign body in a female. So the mother is supposed to adapt to that foreign body. Now it is used to the spermatozoa of someone here. And then you decide to change. So it means that will become a very foreign one. You see that, Dr. G? Yours will be most foreign. And there will be a reaction, which will manifest in form of pre-eclampsia. No wonder change in male partner becomes a risk. Okay. Away from risk factors, let's go to pathophysiology of pre-eclampsia. Now, I've put several theories. Pre-eclampsia has always been known as a disease of theories, meaning it's not well understood. But as days and weeks and months move, we keep understanding it more and more. So probably we'll catch up with it very soon. The same way we are catching up with HIV. Okay? So I again urge all of you to be reading. Every day update, at least talk on a weekly basis if you so wish, or every day if you can manage. Update yourself on all the conditions you've learned in medicine. What is now happening? What's the most latest information to do with that condition? Okay? So you can't rely on a book that you used, like for instance, the 10 Teachers, 5th edition. You won't find what was found out to be the issue in the last 1 week. So medicine is an ever-changing science, and we need to keep updating. So I'll give you theories which are latest, but I will not delve into postgraduate arguments, but I'll look at what is acceptable. So I've given you 3 theories. One is defect in trophoblastic invasion. The second one is release of anti-angiogenic factors into maternal circulation. So there are some chemicals being released in maternal circulation. The other one is systemic inflammation, but there's something common about this. And the last one is the immune theory, which I'm just talking about. So these four maybe can try to make us understand pre-eclampsia. But there are people who have even tried to put these theories together by what is called the Riedman et al. Two-stage theory of pre-eclampsia, as if it's a two-stage process. But again, like I mentioned, that would take us into postgraduate. Now, let me explain something very simple, and I'll take my time. Simple, because it's something that you know, and we partly discussed it under the menstrual cycle. When a sperm comes through, it meets the secondary oocyte together with its extruded first polar body, surrounded by the cumulus. Now I think I'm being complicated. Okay. Let's say an egg and a sperm. Again, that's too simple. They fertilize and then they form what looks like it. I don't know what you can call it. But it initially is called the blastomere. Then as it is going back in towards the endometrial cavity, it changes and becomes a morula somewhere here. Then from morula, it becomes a blastocyst. Now, this blastocyst is known by having two parts. The first part is called the inner cell mass, which is this one. The inner cell mass is what becomes the embryo. It becomes a trilaminar disc. Remember? Yes. The ectoderm, the endoderm, and in between you have the mesoderm. Yes. Again, the mesoderm has got the paraaxial, we have the intermediate, and we have got the lateral plate mesoderm, which divides into the splanchnic and somatic layers. In between there, you have the neurotube and the notochordate. That story. Now, I'm not interested in the inner cell mass. I'm interested in the outer coverings of this. If you remember, the outer layer was called the syncytotrophoblast. The outer syncytotrophoblast is the one which secretes beta-HCG. And then comes the inner cytotrophoblast, which is that unicellular layer, which is made up of that. Not so. This box one by one, looks like simple cuboidal cells. Now, what is supposed to happen is that this blastocyst is supposed to get attached to one of the walls of the uterus, right? Now, we know that if you look at it from without inwards, we have, of course, here we have the serosa, we have the myometrium here, we have the endometrium. So it's basically parametrium, myometrium, endometrium. Now, this blastocyst is supposed to attach itself to the endometrium, right? Now, this lady is now pregnant. Are we still going to call it endometrium? No. The name changes from endometrium to decidua. From endometrium to decidua. And I will not go much into histology in terms of the compacta and the spongiosum and whatever. But let me just simplify it for you. To say when this blastocyst is approaching, it needs to become this. It will enter into the decidua. Now, this part of the decidua, which is directly in contact with the blastocyst, is given a special name. It's going to be called the decidua basalis. It comes from the base. Okay? Then it will continue going deep inside the endometrium, meaning that it will be covered by another decidua, which seems to be lagging behind and trying to cover it. And that decidua is known as the decidua capsularis. Right? Then there will be this other part of the endometrium, which is not participating in implantation. It will also have a name. It's called the decidua vera, or the decidua paretialis. So all these deciduas have got other names, but let's just simplify it to say decidua basalis, capsularis, and the vera. Now, let us conclude by looking at the syncytotrophoblast, or the blastocyst itself. You can see that there is part of this outer layer which will be in direct contact with the decidua basalis. Do you know what will happen to it? It will have projections. In fact, these are the projections I'm talking about. And if you look at these, they look like branches of a tree. And this other side, those projections won't be there. Very fun. So this side where there will be no projections because it's not in contact with the decidual bursalis will be called the chorion larvae. And this other side will be called the chorion frondosum. We did embryology. Now, why are we talking about all these things? These things are important in understanding how pre-eclampsia comes about. Now, let us zoom. This is exactly what is here, but I've zoomed it here. Let us see what happens when the blastocyst gets into the endometrium and gets closer to the myometrium. What is exactly happening? The first thing you need to realize is that on the outer margins, particularly in the lateral borders of the uterus, we have this vessel known as the uterine artery. Remember? So the uterine artery will be sending branches into the substance of the uterus. Artery climbing, getting towards the corneal aspect of the uterus. It will send branches into the myometrium, right? And these branches have got names. There is the basilar, the arcuate, the radial. But eventually, when they reach the endometrium, they will become spiral. Why are they spiral? Because they are in the luteal phase. Right? For you to get pregnant, it means you're probably in the luteal phase. So, this becomes spiral. Now, what is going to happen is that this blastocyst is coming. Now, when it gets closer to the decidual bursalis, what it will do is it will behave in 3 ways. It will behave in 3 ways. 1, 2, and this one I did not complete, but it's this way. Is another one. This is the 3rd way. And that 3rd way even continues to seem to be going up again. Now, what is this, what I'm talking about? So the first thing, and I'm simplifying it, is that the cytotrophoblast will seem not to be doing anything, but the inner cytotrophoblast will send out its cells, and these cells will behave in how many ways? 3 different ways. The first way is number 1 here. They will form what is known as the endovascular trophoblast. So these will come in and then will invade the lumen of the spiral arteries. Imagine, they go inside. So this is the spiral artery, and then this one, which I've been given the Rampley's forceps, is the cytotrophoblast. So it is entering and eating the walls of the spiral arteries, meaning the endothelium. Now, this is just one way. The second behavior is where, this one, number 2, where they form primary, secondary, up to tertiary chorionic villi. If you hear of chorionic villi sampling. So these ones are not entering into the blood vessels, but they are just coming directly into the decidua and then forming like some bit of branches. Have you seen that? That is the second behavior. The last behavior is this one, number 3, where they come out, they bypass everyone, and then they form a layer to more or less block. And this layer is given a special name. It's an area of fibrinoid degeneration known as the Nitter-Boots layer. And I think I talked about it last time to say, if invasion of this placenta to be goes beyond this layer, you end up with placental accreta. Okay. Now, let's go back to the first behavior. Why is it behaving like this? When the endovascular trophoblast enters the spiral arteries, it enters into 2 waves. So between 12 to 14 weeks, they enter. right? Then they take a 2 weeks break. Then, so meaning nothing happens in 15, nothing happens in, but from 16 to 18, they again enter deeper. In fact, they even enter into the myometrium, almost bypassing the endometrium and going into the myometrium. Get the point? So they do this invasion in 2 waves. The first wave and the second wave. Now, the problem with pre-eclampsia is a defect in the second wave of trophoblastic invasion, not the first wave. No wonder the problem starts after 20 weeks, because we are saying between 16 and 18, that was the problem where pre-eclampsia came from. So you start seeing the effects from 20 weeks. Clear? Then, what happens during invasion? When this thing is invading, it's causing a lot of inflammation because it's basically rough, passing. Now, when there's inflammation, there's release of both vasodilatory and vasoconstrictory cytokines. Now, what normally happens in normal life is that there should be more vasodilatory than constrictor. If you are to weigh them on the scale, there should be more of dilatory than constrictor. Meaning that there should be more of prostaglandin I2. The other name for prostaglandin I2, you need to know it, is called the prostacyclin. Prostacyclin is prostaglandin I2. Then there is nitric oxide. These are some of the examples of dilatory cytokines. Whereas vasoconstrictory one is TXA2, which is thromboxane A2. Now, if you have this equation where we have more dilatory than constrictory, what will happen to the spiral artery? It will undergo what is called remodeling. Remodeling is not like models. You've seen those models. Is it Miss or Mrs.? Mrs. Chinsai. When they undergo remodeling, it's like they change their structural outlook. They will now become funnel shaped. This one is what is becoming this one. This one becomes this one. So they become funnel shaped, low resistance, high capacitance, and the name is even changed. They are no longer called the spiral arteries. They will be called uteroplacental vessels. Uteroplacental what? Vessels. So it's because you had more dilatory, no wonder they've opened up. Now, why are we calling them low resistance? It's because blood can now easily move to and fro, very easily. Secondly, they are high capacitance because they can keep more blood. Now, why are these forming? Because this one has formed the uteroplacental vessel, this one has formed the uteroplacental vessel, and you can see these vessels are in between those cytotrophoblasts, which are forming the chorionic villi. You've seen that, eh? So they are like interchanging. Chorionic villi, UP vessel. Chorionic villi, UP vessel. Chorionic villi, UP vessel. Now, what is going to happen is that if you look very carefully, back to my diagram here, the syncytiotrophoblasts has got little spaces known as the syncytio nodes or the syncytio lacuna. So those tumor spaces are these tumor ones I've written in dots. They will become big and become part of the uteroplacental vessel, because this will reach before this one. This one will become part of the UP vessel. So do you know what will end up happening? It's like you end up with just big spaces. We can't even call them vessels anymore, because they're just big vessels. What can we call them? Sinusoids. You get the point? Just like if the liver could be sinusoids, a space of this, say, the hepatic triad, which passes through the right free margin of the hepatoduodenal ligament of the lesser omentum. What are we talking about those things? We are talking about the placenta. Now, this sinusoid. So let's look at how blood moves. A fetus is, or embryo is this side. You see? Its blood will pass through like this, enter, then go back. Come here, enter, go back. You get the point? Then also the uterine artery of the mother is coming, sending blood, entering and going back. So it's like blood is going this way, this other one is going this way. These two bloods do not mix. No wonder you can find that this one will be B plus, this one is O negative. It's possible. Because these two bloods don't mix. But then they come very close to each other where there will be exchange of nutrients. This is what happens in the placenta. And this is the part when you remove the placenta which forms those cotyledons. You know, when you have removed the placenta, you are saying, no, this is the fetal. No wonder we call this part, is it the fetal side? And then that other side, this is the fetal side, and then this is the maternal side. Because this is the one which is collaborating with those cotyledons down here. And then this other side, don't forget there will be the amnion and the umbilical cord. So this is what we see when we look at the placenta. The amnion is the plastic, and then the chorion is down. And then you find those chorionic vessels, which are basically these ones. Okay, so this is basically like an immature placenta. Now, let me conclude by saying, I'm almost done with this diagram. Let me conclude by saying that, maybe you might be wondering what makes a primary and a tertiary villus. The primary villus is when there is no blood vessel in it. Once there are blood vessels in these projections, then it's called the tertiary villus. Meaning circulation is possible, meaning they have been replaced by the mesoderm, the extraembryonic mesoderm, going into the extraembryonic coelom, and all those funny things that we used to learn. So, now, what I'm trying to say here is that in pre-eclampsia, now let's follow me in pre-eclampsia. In pre-eclampsia, what would have happened is that because of the defect in the trophoblastic invasion, there will be more production of vasoconstrictors than vasodilators. Imagine, the other way around. So this vessel will not change from spiral to funnel-shaped uteroplacental vessel, but it will become like this. Meaning the opposite. Instead of being low resistance, there will be high resistance and the low capacitance. And this is because of failed remodeling. And because of failed remodeling, what could have happened is that... Okay, so what we are saying here is that in this pre-eclamptic situation, what would have happened is that there will be more vasoconstrictors than dilators, and then you end up with a vessel which is opposite a funnel shape, but it will be very small. So what will happen if that is the case? Do you think this placenta will have blood supply? It will become ischemia, there will be hypoxia, right? Okay, that's one of the things that will happen. And you have the cascade of other problems that will arise. Now, let me stop there. Why is it that we give low-dose aspirin to prevent pre-eclampsia in one who you think has a risk? Somebody tells you I had severe pre-eclampsia, they even stopped the pregnancy, I even convulsed, I did all those things. When you give the aspirin at low dose, meaning 150 milligram and below, what we'd have done is that these chemicals I'm putting here, they come from one source, arachidonic acid. So when you follow arachidonic acid pathway, it will give you somewhere there leukotrienes, prostaglandins, and all kinds of funny things. Now, in other words, it's giving you almost like both of these. But when you give aspirin at low dose, it will block the vasoconstrictory pathway. And it will leave this one untouched. So it will only go to block the vasoconstrictory pathway. Meaning that the dilatory ones will continue being produced more, so that you don't have that imbalance. You get the point? So 150 milligram once a day, or 75 milligram once a day. And it can only make sense if you gave that aspirin before the second wave. Imagine you start giving it at 25 weeks. I mean, this damage has already happened. It will be of no use. So you need to start at age. No wonder our guidelines are saying you start it at 12 weeks. Yes, so you start giving aspirin so that you reduce the chances of pre-eclampsia. So that is one of the things here. If you give it at high dose, like 300 milligram, the one we use for pain relief, it will block both. What have you achieved again? Nothing. And so, but of course, you can read more in terms of platelet aggregation and what in terms of platelets. But basically, that's how we use it in pre-eclampsia. Now, if this is the situation, what will happen is that there will be endothelial dysfunction because you have damaged the endothelium. And this endothelial dysfunction is the single most cause of problems in pre-eclampsia. It's the one which explains why there is eclampsia, why there is the epigastric pain, liver capsular rupture, why there is the acute kidney injury. All those are explained by endothelial dysfunction. Now, initially we thought that pre-eclampsia was purely explained by defect in trophoblastic invasion. But now, further studies have shown that no, this endothelial dysfunction has another pathway which leads to it. And that pathway is release of angiogenic factors. Remember, angiogenesis is production of new blood vessels. Now, it's like we have factors which are making blood vessels. We also have factors which are blocking production of blood vessels. Imagine. So we have placental growth factor, which is very important. We are now going to be using it as a predictor of pre-eclampsia. And there will be a big study that will be done in Zambia. I don't know if it's now underway, where they want to use placental growth factor to see the levels. Because it's a fight between angiogenesis and anti-angiogenesis. Okay? Now, which are those angiogenic ones? We have these two, SFLT1 and SENG. I'm sorry, I'm not the one who created this. But in your own reading or in my notes, I can write for you. So the SFLT1, you just need to know these two. It's soluble FMs like tyrosine kinase 1. Soluble FMs like tyrosine kinase 1. And then this other one is known as soluble endoglin. These are the problems also. And if people can find ways of suppressing these two, then it means that we will minimize this. The other one is systemic inflammation, which I don't want to talk about. It's basically the same thing I was talking about. But then these three, 1, 2, 3, what are they doing? When they cause endothelial dysfunction, there will be generalized vasoconstriction, which you have seen here. And as if that's not good enough, there will even be vasospasms, which explains part of those things I was talking about. Fitting, what. And then, what will happen if you are constricting the blood vessel? Water will extravasate. You end up with edema. Now imagine somebody has edema and you start giving furosemide in pre-eclampsia. What are you doing? You are even diminishing the little vascular volume that the patient has. So it's extremely dangerous. We only use furosemide on a risk-benefit scale when probably we are treating pulmonary edema. In addition to the CPAP or BiPAP, we even add furosemide. But otherwise, it's not one of our nice drugs using diuretics in pre-eclampsia. Now, so we call it a constricted space. Then what will happen? Generalized hypertension. Because where do you think this hypertension is going? Is it going on the mother's side or on the baby's side? These vessels are rising from the mother's side or baby's side. So on the mother's side. No wonder the problem will go on the mother and not on the baby. The baby will face the consequences of the mother suffering because obviously blood flow back to the baby will be reduced. But that's not really the issue. The issue is that once that endothelial dysfunction starts, it will start following the mother's blood vessels. From the placenta going now into her circulation. Brain, kidneys, liver, and so on. It becomes like metastasis, right? So you see that the primary problem is the placenta. And one, the treatment of pre-eclampsia is remove the baby. Remove the placenta. Because that's your main source of problems. That's all in the pathophysiology, and that's why I wanted to spend time on. For you to just to understand some of the principles at pre-eclampsia. Now I can quickly sweep through in less than 20 minutes pre-eclampsia as a topic. So, having looked at the definition of pre-eclampsia, risk factors, and pathogenesis, of which we talked about several theories, of which I didn't belabor much on the immune theory because I've already talked about it. Yes, which explains certain principles that we find. For instance, what causes pre-eclampsia to be more common in gestation trophoblastic disease and in prime gravidas, and so on and so forth. It's the immune theories, including the change in male partner. Yeah, but again, there's a lot of immunology, and we won't go into that science. Now, away from that, we are now looking at the symptoms. I think we know the symptoms. This is too basic. From the head to toe, we have headache, blurred vision, vomiting, epigastric pain, right upper abdominal pain, and finally, swelling of the lower limbs. Those are the symptoms of pre-eclampsia. What about the signs? When you examine the patient, what is it that you're going to elicit or you are going to detect? So one of the things that you start with whenever you're examining a patient are vitals also. And remember, urinalysis is part of physical examination. That's what we learned in Hutchinson's methods. So the first thing that you need to do is check the blood pressure. It will be greater or equal to 1/4/90 millimeters of mercury. The other thing would be that the protein will be significantly high. Of course, we will talk later about what is significant proteinuria. Now, having mentioned that, a patient who has visual disturbances will end up with what? Reduced visual acuity. Others can tell you, no, I can see you, Dr. Mpane, but you are not so clear. What's with that? You see, it's not clear, visual acuity. The other thing is that, which we always forget, and I'm very, very particular with this, is epigastric tenderness. If you are palpating the patient's abdomen and then you get to the epigastrium and try to go deep palpation, patient will jump in pain. Hey, it's paining here. You go to the left hypochondria, no pain. Maybe the right hypochondria, there's some tenderness, but you can tell that this is localized to the epigastrium. That is a very important sign. So don't only depend on the symptom of epigastric pain, but also objectively assess for epigastric tenderness. Clear? Then the other thing we need to look for is the reflexes. So deep tendon reflexes are brisk and exaggerated. What do you mean by brisk and exaggerated? Meaning they are brief and exaggerated. A normal reflex should be like this. I don't know how many of you even carry patellar hammers. Okay? But in pre-eclampsia, when you hit, it will be like this. Very quick and exaggerated, as if the patient is just doing it deliberately. So if you found that type of sign, then know that you are dealing with the pre-eclampsia. The next one is if this was my foot, and then I did a Babinski sign, what do you think you'll find? Nothing. I just talked about it deliberately because I wanted you to differentiate between Babinski and ankylosing. We all know what ankylosing is. Dorsiflex, there will be rhythmic movement. That is called positive ankylosing. I don't know how many of us check for ankylosing in pre-eclampsia. That's another important sign. And finally, anasaka and ascites. Yes, it's normal for a woman to have edema when they are pregnant, but it should not be too much. Initially, we were using edema as if it was a parameter for pre-eclampsia. It was dropped. But from my little years of experience, thank you, you are my intake mate, or you are my senior ultimate person. Okay, so what you are saying is that from experience, when a patient has got pre-eclampsia and they've got ascites, I'm not talking about anasaka, ascites, that's severe disease. That's severe disease. So, having talked about the symptoms and signs, let's go to differential diagnosis. What can look like pre-eclampsia when in fact it's not? Let's not forget, colleagues, that we are talking about other hypertensive disorders in pregnancy. We talked about PIH. We talked also about chronic hypertension, right? and pre-eclampsia superimposed on chronic. So maybe it's those other three. The other one is a condition which is common in pediatrics known as nephritic syndrome. Not nephrotic, but nephritic. Nephritic, remember, is characterized by hypertension. There is also some proteinuria. And what else? Hematuria. And what else? Kidney dysfunction. So that could be a strong differential diagnosis. No wonder I always emphasize to midwives to say, don't just be checking proteins in urine. You have got that entire dipstick. You are only interested in protein. No, check for protein and blood. Because that hypertension together with blood and protein, and then you do serum creatinine and urea, they are high. Maybe think of nephritic syndrome at the back of your mind, which is basically glomerulonephritis. Dr. Deborah, remember that. The angiocapillary, minimal change, focal segmental glomerulosclerosis, those things will start running through your head. Anyway, the last one is chronic kidney disease. Because remember, chronic kidney disease, there is an ASAC as well. You find BP is high, and you find a lot of protein. Or it could be a urinary tract infection. Imagine the BP is just 150/90, and the protein of 2+ or 1+. It could be a UTI. Right? No wonder you needed to check the nitrates, you needed to check the leukocytes, you needed to check for blood and other parameters on urinalysis. And then also don't forget that you could just be probably dealing with other conditions, like for instance, dyspepsia. Remember, in pregnancy it's normal to have heartburns. Why? It's because of increased progesterone level. The left cruise of the diaphragm can no longer hold the cardiac end of the esophagus, there at the stomach, junction of the esophagus and the stomach. So when the left cruise gives in, that food which is mixed with acid will go back, especially when she changes position, and there will be heartburn. Now imagine you check the BPs, 150/88. Protein, because of some urine lab error, it's 1+. Epigastric pain, what do people say? Severe Pre-Eclampsia, even that magnesium sulfate. That is academic indiscipline. You've missed the diagnosis. So all the time, we need to think of differential diagnosis. What else can it be? Now, let's go to complications. I've given you all this in the notes. Now, when you look at the complications of pre-eclampsia, they are maternal and the fetal. Again, if I was to be the mother, this maternal, imagine I'm in maternal. We having worked a lot in the obs and gyne. So if it's maternal, let me start from the head, or CNS. Don't forget that, again, maternal complications can be general or specific. Why am I calling this? That's my own classification. General or specific. What do I mean by general is that a BP of 200/140 in the male ward is not different from a BP of 200/150 in the obs and gyne. Don't you think they'll have the same problems? They'll have the same problems, right? Meaning it's a general complication because of raised blood pressure. In fact, we call those cardiovascular complications. So which are those? Number one, in the head, it can be a severe stroke, which can be ischemic or hemorrhagic. It can cause confusion in the brain there. What were we calling that condition? Hypertensive? Encephalopathy. But I don't know whether you people call it urgency, emergency. Yeah, I don't know. I'm a midwife. Then comes the eyes. It can damage the eyes, and that's hypertensive retinopathy. And remember the grades of hypertensive retinopathy. Then from the eyes, that is basically the CNS, we now go to the heart. It will cause hypertensive heart disease because there's too much pressure. So the left side of the heart will hypertrophy. Then later on, the Frank-Starling laws will be overwhelmed, and then the heart will just open up, and the valves can no longer touch each other, and you end up with the biventricular heart failure. And don't forget, it can damage the kidneys, and you end up with acute kidney injury. So those complications are the same, be it male or female. Now, as if that's not good enough for that mother, or as if that's not bad enough, that mother also has another line of complications which are due to placenta. Which are those? Meaning that no matter how much you control the blood pressure, use all kinds of antihypertensives, those other complications will still follow you, provided the placenta is inside. Which are those complications? Again, from the top, eclampsia. No wonder we call it pre-eclampsia. It's before eclampsia. Next, cerebral edema. Next, pulmonary edema. Next, we go for the liver. So it can lead to liver failure, or it can lead to liver capsular rupture. Imagine the Gleason's capsule of the liver ruptures. It detaches and then ruptures. I've seen this complication 3 times in my practice. Very bad one. Where you open the abdomen, you are going to do a CS, thinking, is this an impending rupture, whatever you call it, abruption. Then you open, you just find the hemiperitoneum. You check the uterus, the walls are intact. You check the broad ligaments, intact. Then where is the bleeding coming from? So I don't expect Dr. Michipi, you close the abdomen. You just suction and throw. Again, that is surgical indiscipline. You can't do that. So if you thought that this is pre-eclampsia and you know that liver capsular rupture is one of the complications, you extend the incision until you get to the right hypochondria and deal with the problem there. And we'll talk about management of such complications in the next lecture. The other one is the HELP syndrome. We all know what HELP syndrome is. Hemolysis, elevated liver enzyme, and low platelets. So, how would you suspect that this one will have a liver capsular rupture? In fact, liver capsular rupture is a complication of HELP syndrome. So a patient who has severe epigastric tenderness or right hypochondriac tenderness. So you see the importance of examining a patient. Then when you do the liver enzymes, they'll be very high, way above the upper limit of 32 international units, per liter. It will be maybe 1,600 ALT. AST will be almost 2,800. Patient is jaundiced and all those things are there. It's just telling you that this liver will rupture anytime. So you can predict liver capsular rupture if you are very cautious. Then, the other complication is DIC. Why is there DIC? Because of all these endothelial dysfunctions. It will cause DIC because you are now disturbing the clotting cascade and there will be issues to do with platelets. Then, don't forget, it can also lead to placental abruption. Placental what? Abruption. So, finally, which was already a general complication, you can also have acute kidney injury. So the kidneys are in big trouble when it comes to pre-eclampsia. Having talked about those general and specific complications, which are in your notes, finally we look at fetal complications. What are the fetal complications? There are just 3 important ones. The first one is IUGR, because this baby will stop growing. It's not receiving blood from the mother. So it will end up with it. Is it symmetric or asymmetric IUGR? You think it will be symmetric? You think so? Dr. Mtaya and Dr. Mandama Jr., they are colleagues. They are both physicians. Okay. It will be asymmetric. Why? It's because this problem started at 20 weeks. Meaning the baby was developing well and the problem started later. So there will be head sparing. Symmetric IUGR is common when the problem started from way back. Let's say you grow a baby in high sugar from the beginning. That is dangerous, not so? Because it means that the problem will continue perpetuating throughout pregnancy and you end up with symmetric IUGR. Of course, I don't want to talk much about that, but there's what we call fetal biometry when you are doing an ultrasound, where, for instance, I was trying to put my phone. Okay. Where, for instance, you look at the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. Okay, but we'll talk about this maybe later, when you look at the complications of pre-eclampsia with respect to the fetus. So those numbers are very important when you have an ultrasound report. Pay attention to those estimations of weeks by the Hadlock formula to see whether it's asymmetric or symmetric IUGR. The other problem with the fetus will be fetal distress. And if you are to do a non-stress test, it will give you late deceleration. And then most likely, as the last complication, to be IUFD. And don't forget, the fetal demise can be sudden in pre-eclampsia, just like it is sudden in diabetes mellitus, just like it's sudden in sickle cell, just like it's sudden in post-deaths. That's why for me, these 4 conditions, I'm very scared of them, because you are walking on eggshells, as my good colleague Dr. Shalinti George would always say. Because anything can happen. You are trying to buy time for the baby, but you are still walking on eggshells, because anything can happen to the baby. So we need always to be mindful of the pros and cons of our management plans. Okay, so vascular nasal complications. Classifications. We are almost done. How do we classify pre-eclampsia? Pre-eclampsia only has 2 classifications. It's mild or severe. There's no moderate. So, what makes mild pre-eclampsia? It is blood pressure systolic, which is, of course, crossed 140/90, but it doesn't cross 160/110. Between 140/90 and 160/110, in between there, that is mild. Clear? Proteinuria. Proteinuria will be 1+ or below. 1+ or below. So significant proteinuria starts at 1+, but it doesn't go beyond 1+. Now this is the BP or protein or what else? No symptoms and signs. So a patient has got pre-eclampsia, but they have got no symptoms, they have got no signs, which we have just discussed. Or they have got no complications. Now, how do you know that they have got no complications? Some complications can be detected clinically. Imagine somebody is claiming they have got pre-eclampsia, and yet they are coughing, pink frothy sputum. When they cough, it looks like blood. Don't call it hemoptysis and ask for sputum and gene expert. That could be pulmonary edema. Or the patient is just becoming drowsy. How are you? How are you? They can't even open their eyes. They are going down in their GCS. That could be cerebral edema. You get the point? So, or it could be a woody, hard, tender abdomen, meaning that it's an abruption. So those could be clinical features of complications. But some of them can only be detected by the lab, which we shall look at. For instance, liver enzymes are skyrocketing in the sky. Platelet has dropped. HB, maybe it's gone higher, now it's dropping. Or maybe creatinine and urea have gone up in the roof. Or maybe it's LDH. Or maybe it's the fetal parameters. Don't forget the fetal. You find there's reduced liquor volume. The baby is no longer active. You do Doppler and you find some abnormal findings. So we need to look at both clinical, lab, and the radiological parameters. If the patient doesn't have any of these after you do those investigations, then what do you call it? Mild. Are we together? So it means that severe pre-eclampsia is just the flip side. Meaning that when we got back up to blood pressure, it will be BP above 160/110. That's one. Or proteinuria of 2+ and above. Or there are symptoms and signs, meaning patient has headache, blurred vision, all those, some of them can't even see you because they've lost the sight temporarily. Or they have all those signs which we are talking about, ankylosing, reflexes. Now, what special name are we going to give severe pre-eclampsia where there are symptoms and signs? It's given a special name, Dr. Tem. It's called impending eclampsia. Impending eclampsia. So impending eclampsia refers to a form of severe pre-eclampsia where symptoms and signs are present. And please, don't forget, I'm mentioning symptoms and signs. So, why do we call it impending eclampsia? Because those become like pre-ictal features of a fit. So if a patient tells you, no, I'm having pain here, I'm vomiting, you touch there, then it means as if any time they will convulse. So no wonder it's called impending eclampsia. That's an emergency. You need to act quickly and start magnesium sulfate and everything. The last one is where the complications are present, which I've just talked about. So what this means is that even if the BP is 148/92, protein 1 plus, but then there are those complications, then that is severe preeclampsia. Not so. Because it fits in one of those parameters. Now we don't have a defined criteria to say 2 or more of these, or 3 or more. No wonder you need to widen your history, examination, widen your profile of investigations, so that you are convinced that this is severe preeclampsia. Imagine somebody just has a headache and the BP of 160/110, and you call it severe preeclampsia. So you have to stop my pregnancy, terminate it, when that is a precious baby. Of course, all babies are very precious. Do you think clients will accept? They won't, and they are right, because you have used only 2 parameters to consider it to be severe preeclampsia. No wonder we need to widen our diagnostic capabilities, so that we check this, we check that, and be convinced at the end of the day to say, what are we dealing with? Because if it's severe preeclampsia, you have to deliver within 24 hours. You see the difference? So it's a big decision to attach the severity to preeclampsia, because that will change the course of your management. And you have to be sure that you are very sure of what you are doing. Now we conclude by management. The last part. You know, in movies there was the last fight. Where if it was that one, who was Steven Seagal, him was never beaten. Even 8 people with guns, not even a scratch. So now we are in the last fight now, management. Now, let's look at management of preeclampsia. In management of preeclampsia, there are what are called blocks. I've written for them nicely in your notes. I don't even need to talk much about them. They are called principles of management. What do we mean by principles of management? They are like blocks, categories. So you put a category, then under it you put something. You put a category, you put something. That is a good way of writing your management plans. Because remember, management is investigations and treatment. That's all. So, what is the first principle at managing preeclampsia? The first principle is rule out complications. You are seeing a patient with BP of 160/120, albumin 3+. You want to know, are there complications already that have set in this patient? So how are we going to do that? You admit the patient, secure IV access, maybe a 16G or whatever G. Then next, you collect blood because you are cannulating, right? So what blood are you collecting? The first blood you are collecting is a group 1 self. 2, full blood count. Because of the HELP syndrome. 3, liver enzymes. I don't want to call them liver function. Liver enzymes. But we are interested in ALT and AST. We are not really interested in ALP and GGT. I think we discussed that during the major round. Those are used for something else. So we do liver enzymes. We also do serum creatinine and urea. But sometimes you can also do uric acid. There's a difference between uric acid and urea. Then, don't forget one important marker which sometimes we tend to forget is LDH, lactate dehydrogenase. What do you think it's used for? It's the best marker for DIC. So for DIC or HELP syndrome, basically, in fact, let me just say HELP syndrome, not DIC. DIC, I think I did mention, we normally use serum fibrinogen. But for HELP syndrome, we don't use serum bilirubin, but we use lactate dehydrogenase. Okay, so if it's skyrocketing above 600, it's now 1,000, 1,000, 2,000, it means that there's active hemolysis going on, microvascular hemolysis, and that's a very important mark. So that's biochemistry and full blood count. The next thing that we need to do is the bedside clotting time, because of the risk of DIC. Clear? And remember, in preeclampsia, the DIC is the Mountford. Why Mountford? Because preeclampsia causes DIC, abruption causes DIC, and the dead baby causes DIC. I think we have 3 things pointing to DIC. So it's good that you check for those complications. The other thing is that you need to do fetal parameters. Because how do you know that this fetus has not been affected? You need to do an ultrasound. But not just an ultrasound which will give us the placental location, the grading, and the weight. All those are important in your management in terms of prognosis or mode of delivery. But you also need to do a biophysical profile. So meaning you need to know the fetal gross body movement, breathing movement, fetal tone, and everything that Manning's has exemplified in the biophysical profile. You need to do a non-stress test. You need to do Doppler wave studies. In fact, that will be another lecture when we will just look at assessment of fetal well-being. So that when Dr. Chisi says fetal distress, we are all convinced. It's not just based on a fetal heart which has gone to 8 or to 160. Dr. Mpangi, remember that lecture? Yes. Okay. Now, having said that, we have ruled out complications. What else should we do? The second principle is lower the blood pressure. And what drugs do we use to lower the blood pressure? It's nifedipine, it's methyl-dopa, it's labetalol, it's hydralazine. In OBS and GYN, we only use 4 drugs. Nifedipine, methyl-dopa, labetalol, hydralazine. So the dosages and the side effects of these drugs I've given you in the notes. It's important to know the side effects. Why don't we use atenolol? Atenolol will cause IUGR. But why are we then using labetalol? So labetalol is very interesting drug. It allows the blood pressure of the mother to drop. I can direct you to this one. It will drop the blood pressure of the mother. Now imagine if you drop the blood pressure of the mother, what will happen? The blood flow to the baby will be reduced. Because don't forget, those vessels are already narrow. Now you are even dropping the blood pressure. Meaning that high blood pressure is good for the baby. So when you use other antihypertensives, what they will do is that they will protect the mother, but it will be very detrimental to the baby. And therefore the baby will end up with the intrauterine growth restriction. Now, labetalol has effects on alpha receptors and beta adrenergic, and it has also got what is called intrinsic beta sympathomimetic activity. I take you back to books of pharmacology. So no wonder you find labetalol becomes one of the best drugs in pre-eclampsia. It reduces the BP on the mother, but increases blood flow to the baby. Imagine. So that is it about labetalol. So mostly if it's oral, we give 200 to 400 milligrams BT per oral. That's the oral one, not the IV, which is 20 milligrams. For methyl-dopa, you can start from 500, not 250. 250 is too small. 500 up to 1,000 milligrams, 8 hours. Side effects, CNS. Why saying CNS? Is because methyl-dopa is a prodrug. It converts into another thing. Then that thing goes into the medulla oblongata, brainstem, and acts on the alpha-2 presynaptic receptor, and then has effects on the adrenal medulla, meaning it reduces the secretion of epinephrine and norepinephrine. So it's a very indirect pathway, and that's why it has got a lot of side effects, CNS, like insomnia, depression. That explains why when a mother who was on methyl-dopa and has had a poor outcome, FSB, early neonatal death, you have to stop the methyl-dopa and switch it with another drug. Why? Because they can easily go into postpartum depression. Then nifedipine, we all know our good drug. We can start from 20, go to 40 milligram PD. Side effect is headache. Why is there a headache? It's because it opens the cerebrovascular vessels. But that side effect can be countered with analgesia, and so on and so forth. So basically, that is it about the control of blood pressure. Let's go to the next principle. Prevent seizures. How do we prevent seizures? We have to give magnesium sulfate. Now, magnesium sulfate is used to prevent seizures and also to control seizures, both. Magnesium sulfate, we all know the protocol. The loading dose, which is 4 grams IV, then 5 and 5 IM, which makes it 4 plus 5 plus 5 is how much? 14 grams, right? But the specifics of the percentage solution, whether it's 50%, 20%, and how much of the lignocaine you give, and all those we all know. They are on the charts in our labor wards. What do you call that regime of giving magnesium sulfate? It's the Pritchard regime. Otherwise, there are other regimes like the Zuspan, the Subai, the Sokota, and other regimes which we don't commonly use here. Now, away from control, now how does magnesium sulfate work? Magnesium sulfate's mechanism of action is not well understood. We just know that it works, but don't know how it works. But one of the ways in which we know at least how it works is that it acts on what's called an NMDA receptor, which is N-methyl D-aspartate, to prevent problems in the brain like convulsions. But most people would say it's a membrane stabilizer. Because if we go back to the action potential, remember there are those small waves away from the resting membrane potential which are trying to reach the threshold potential. Because from threshold potential, it's an all or none law. But you are trying to raise the threshold potential so that they don't reach there. So that's how magnesium sulfate stabilizes the membrane. So that the risk of having now seizures is reduced. You see now it takes us to pharmacology. Now, away from magnesium sulfate, we go to the third principle. I'm almost done. Third principle is the enhancing fetal lung maturity. Enhancing fetal lung maturity. So how do we enhance fetal lung maturity? We know that we can either give dexamethasone or betamethasone. And the best one is beta for betamethasone. Why? It's because for betamethasone you give 12 milligram BDIM for 2 doses, meaning for 1 day. Meaning if you are pressed with time, you can quickly enhance the lung maturity within 24 hours. But for dexamethasone, it will take 2 days because you need to give 4 doses of the 6 milligram BDIM. But anyway, you have to enhance fetal lung maturity. But we know that our friends are even able to do fetal lung maturity tests like the LS ratio. They can do the phosphatidylglycerol, the lamellar body count, and the foam test and other things that will be sure that these lungs have matured. In conclusion, we go to monitoring. What should you monitor when you have a patient with pre-eclampsia? You need to monitor fetal parameters. Which are those fetal parameters? Fetal heart rate, kick chart, right? And 2 weekly biophysical profile. What should we monitor on the side of the mother? Blood pressure profile. Meaning if they do blood pressure once a day, they should do it maybe 6 hourly. That's a profile. They should be doing daily urinalysis. What else? If the patient is on magnesium sulfate, we need to monitor the magnesium sulfate parameters. So we check for respiratory rate. Never have your respirations drop below 12 breaths per minute. Don't have your urine output drop below 30 mL per hour or below 0.5 to 1 mL per kg per hour. And then don't have reflexes lost. Remember your reflexes were like that. Now imagine you hit next time and it's just like this. You've lost your reflexes. Dangerous. It means that magnesium level in blood is rising. Why are we worried about magnesium? It's because magnesium has got a narrow therapeutic index of just about 4 to 9, if I'm not mistaken, milliequivalent per mil. Meaning that it can easily shoot its safe level or safe range. And so the best would have been to do serum magnesium, which you can use an ABG machine for. No wonder we always emphasize our hospitals should have ABGs. We use ABGs for a lot of things. For diabetic ketoacidosis, for monitoring a patient who's on a ventilatory machine, and many other metabolic reasons. But one of the reasons why an ABG is important is you can check serum magnesium instead of using the biochemistry machines in the lab and then be able to tell that the magnesium is high. But here, because we can't do serum magnesium, what do we end up doing? We are starting following clinical parameters of toxicity, which might be subjective and they might be late. But we have had no issues with Pritchard regime so far. Now, the issue is, why do we check urine output? Does it mean magnesium damages the kidneys? No. Magnesium does not damage the kidney. But a kidney that has been damaged by pre-eclampsia will not excrete the magnesium. Meaning that you'll be giving magnesium, but the kidneys are failing to discharge the magnesium. So you easily go into toxicity. No wonder when you are doing the urine output, you are not doing it because we are worried that magnesium is damaging, but it's because we know that magnesium is not being excreted, and that is liver. Now, from monitoring, we finally go to definitive management. What's the definitive management? And that's the final one. You shall see later when we talk about complications of pre-eclampsia that we do extra monitoring. But here we're talking about pure pre-eclampsia without complications, with or without symptoms and signs. Definitive management. So the first thing that you need to consider is you ask yourself, what's the gestational age? If the pregnancy is below 28 weeks or 24 weeks, whichever you consider as the age of viability, then cancel for termination of pregnancy. But that way termination of pregnancy is very rough. Huh? Remember like that Arnold Schwarzenegger movie, Terminator, very bad. So let's be using nice terms like pregnancy interruption. Let's interrupt the pregnancy. So we cancel for, to tell these people to say, even if we were to give you extra 2 weeks, because in pre-eclampsia you don't usually want to go beyond 2 weeks, if it's indeed severe pre-eclampsia, or even mild, because this problem can just worsen. It's a progressive disease. So the more time you are spending, the more the trophoblastic invasion, the more the complications are following you. So you just have to tell that couple, we are very sorry. We understand this is your first pregnancy. You got married last year. But unfortunately, we have no choice but to stop this pregnancy. Because this pregnancy will just take you and your growing baby. You will lose both. So you have to cancel. But if you find that the pregnancy is salvageable, meaning it has crossed at least 30 weeks, 31, 32, colleagues, you can do something, right? Meaning that you can just optimize the fetal lung and quickly deliver the baby. And I've already outlined those principles. So you keep the patient in the hospital and go by that management, which is more of expectant or conservative management. But don't go beyond 2 weeks. If you are at term, then why should you wait for anything? Just deliver. If the patient is at term and is already in labor, then expedite the process, meaning do some continuous fetal monitoring and rupture the membranes and put some oxytocin so that the process is a bit faster, because for pre-eclampsia we have got a 24-hour threshold. So you can induce, you can expedite, you can augment, but just make sure that pregnancy is out. Now, let's look at induction of labor versus cesarean section. For you to do an induction of labor, you should meet the prerequisites for induction of labor, which will be another topic. Meaning you should do a Bishop's score, you should do a non-stress test, you should have done an ultrasound, and everything else. Then you should be sure to monitor the baby very closely. You get the point? No wonder sometimes you find a situation where we can't even do induction because we don't have, but here we can boast as inside specialist hospital, we have all the monitoring parameters. We're able to do Doppler velocimetry, we're able to do CTG, we're able to do everything to monitor the baby throughout. Okay, but if you think you don't have those parameters, then it's better to err on the side of caution by doing a cesarean section. Okay, but if you think you can manage doing an induction, then do it. But what is painful is to lose a baby when you had reached them and you had the time to remove the baby safely. Then you go by an induction process. You find 2 days that we are inducing and the patient is 8 weeks with severe PE. Does it make sense? Isn't that indiscipline? Yes. So even an induction has got an end point. For me, I don't go beyond 24 hours of induction. Meaning, I do misoprostol. Second one, maybe I even do misoprostol plus catheter. If by the third assessment, the patient is not in active phase of labor, then it's failed induction. I'll go for cesarean section. So within 24 hours, I should make a decision. Now, let's conclude by saying cesarean section is for obstetric indication. What do I mean by obstetric indication? Failed induction, fetal distress, or patient tells you she was a previous Caesar, or she had BOH, or other things, or breach, or other abnormal lie, like transverse lie, and things like that. Then in that case, you are justified to just go straight for cesarean section. One that you can't say, the reason why I've offered cesarean section is because of severe pre-eclampsia. People will be shocked. Is severe pre-eclampsia an absolute indication for cesarean section? No. But if you say severe pre-eclampsia with something, then we can be justified. Or if it's around 30 to 32 weeks, you say we are doing a cesarean section to optimize fetal outcome. Maybe it can be accepted. So basically that's where I could end. We shall see later for eclampsia that for eclampsia we consider the Bishop score. Why? Because we have to deliver a baby in eclampsia in 12 hours. Do you think in 12 hours you can give misoprostol and achieve a delivery? So if the Bishop score is unfavorable and it's eclampsia, then you shall say eclampsia with poor Bishop score. But we don't use that diagnosis for severe preeclampsia. Why? Because we've got 24 hours, which is quite adequate for you to improve that Bishop score and achieve a delivery. I rest my case on this topic.